Thank you for inviting me to share our experience, and apologies for taking your lunchtime. I'll try and finish it as much as I can, as fast as I can as well. And also thank you for all my previous speakers, actually. So they have laid the foundation really well. So what I'm going to share here is that how to speak to people's hearts and minds, mainly about facts and reasons why patients benefit from it, and also to share some early examples of and evidence of how AI can be implemented and it can benefit patients. And also, if I have time at the end, I'll also share some learning from our experience. So a little bit about stroke, and if you know that in our population of 67 million, and one patient has a stroke every 5 minutes, and the radiologists who look after stroke CT imaging, you would definitely know that. About 100,000 strokes per annum, causing about 38,000 deaths every year, and stroke is the leading cause of disability, and it's costly. Just the NHS cost alone is about 3 billion per annum, but if you add it to loss of productivity, that's another 4 billion. And we have about 107 stroke centres in the country, and out of 107, about 24 are providing the mechanical thrombectomy treatment. So a little bit about patients. So as you can see that you're all radiologists, I do not need to go into the details. So axial imaging of two identical scans, obviously the patient on the right, slightly older, you can see that from the little bit of an atrophy of the brain. As you can see on the right MCA, we have the hyperdense MCA sign, which means that the middle cerebral artery on the right side is blocked. And these are two patients that we personally looked after. Patient A was in his mid-60s, patient B is a fit and young gentleman, a police officer in his 50s. And both of them were treated in our centre, and these are the brain scans of those patients 3 days later. The first person has had thrombolysis and mechanical thrombectomy, except for a little bit of a petechial hemorrhage in the basal ganglia region on the right side. The brain is fairly intact. And the poor gentleman, despite being younger, he just had the thrombolysis alone, but not the mechanical thrombectomy, ended up with a hemicraniectomy and a large defect and a large stroke. And this poor gentleman ended up in a nursing home for the rest of his life, despite being younger. What made the difference in these cases is the mechanical thrombectomy. So as you know, for every patient we treat with mechanical thrombectomy, one person is going to be better in terms of outcomes. So it's one of the revolutionizing treatment in stroke in the last 20-25 years. It really makes a difference to the patient. How do we offer this treatment in the UK? So these are offered in comprehensive stroke centres. So if a patient lives next to this comprehensive stroke centre, they are taken directly for mechanical thrombectomy. We call it a mothership model, because they go to mothership directly. But patients do not choose to live next to a super specialty hospital. They can live anywhere they would like to. So if they live in a rural area or away from a neuroscience center, they come to an acute stroke center. And in the acute stroke center, you have to do all the investigations. That means you need to do the scan, CT, CTA, you need to get that, identify the large vessel occlusion, and call the comprehensive stroke center, refer the patient, call the ambulance back, put the patient back in the ambulance and send them back. As you can see how time consuming this process is. This is the drip and ship model. In this model, the door-in, door-out time is absolutely critical. We try to bring it down less than an hour for those patients who benefit as well, the patients who are going to the mechanical thrombectomy center directly. But as we all know, in a large vessel occlusion stroke, every minute we delay, 2 million neurons are lost. And this is a huge thing for patients. And every 15 minutes delay will be translated to a 1 month of healthy life loss for patients. And this is the data for UK for mechanical thrombectomy for 22-23. As you can see, those circles are various neuroscience centres dotted across the country, and you can see the variation. Some centres have only provided 16 mechanical thrombectomy, whereas some of them have done 200. So significant variation. And if you look at how many patients are going directly to the mechanical thrombectomy centre, only 50%. The 50% are going through this longer route, so we need to make that route as efficient as possible for those patients. And if you look at the door-in, door-out time, we would like it to be less than 60 minutes, but for country, this is more than 2 hours. And how many of them are having this treatment? 10% is eligible, and during that year, only 3%. have the treatment. So not many people are having the treatment, and there's a huge variation. And when they're actually being referred, they're not being referred on time. So what can you do? So there are several things in this pathway that you could do. So this is about identifying the need and whether AI is the right solution to fix it. I'm not saying AI is the only solution to fix it. You have to look at the whole pathway, ambulance, pre-hospital triage. Every bit of the pathway is important. But AI can play a role here. What can it do? So if you look at the acute stroke centers, the stroke physicians do see these CT scans and make a decision about thrombolysis. But when it comes to CT angiogram, not all of them are competent enough to look at those scans and make a decision confidently if there is an LVO or not. So if we have any of the system in place to help those clinicians at front door to make their decision as fast as possible, that helps. And we all do on-calls overnight. When you're on call, I'm not sure about the radiologist, we get given a small laptop. And it takes about 10 minutes to boot up, and sometimes you forget the password, enter it 3 times wrongly, it locks you out. And so that's another problem. And once you've identified, transferring the images to comprehensive stroke center is another issue. IEPs are really slow. And there's a way we need to transfer the images much faster. So is there a solution that can give you all 3 of them? Yes, AI can do that. So what we did, we implemented artificial intelligence at the front door. And that helps the front door stroke clinicians or an ED clinician in terms of identifying it, and also it can transfer the images remotely to the comprehensive stroke center. So what it does, we use Brainomics, which is very similar to the other product which is being used by several other hospitals, Rapid AI. So what we get is when we can have an access on our phone. So it's a remote access. As you can see, the video is not quite working yet, but when you click the app, you get all the images that you need. So on the right-hand side, you've got a non-contrast CT, and AI calculate the aspect score for you. It normally takes about 5-6 minutes for us to do it, and also there's always inter-rater variability. So you get that information correctly and quickly. And the second image, you can see the red circle identifying where the large vessel occlusion is. So these are the 2 information the stroke physician you need at the front door to make that decision. While you're making the decision, you can share the images to the referring center, and then they can look at the images and make a quick decision. So that's the basic idea of that. So we implemented it first in our region at the Royal Berkshire Hospital. So we wanted to see if this worked, if it benefited the patient or the pathway. So what we did, a pre and post analysis before and after implementing AI. And then we were really surprised to see the results was very impactful. The door-and-door out time, before we introduced artificial intelligence, the median door-and-door out time at the Royal Berks was 140 minutes. But after the introduction of AI, that reduced by 60 minutes to 79 minutes, actually. So it's a huge reduction in the door-and-door out time because we were able to identify and share the images much faster. And it's all about patients. Patients is in the center of all of it. So was there a better patient outcome? Certainly it was. After we introduced the AI, 3 times more patients were independent after mechanical thrombectomy. This is nothing to do with the AI directly, but it's to do with how fast we were able to make treatment faster. This information now is published in the beginning of the year in Frontiers of Neurology. I'm happy to share the link so you can read the whole paper. And so that's in one hospital. But what happens if you look at the whole network? And I should thank my colleagues, Paul and Ollie from BARTS for sharing this data. So BARTS and the network is the largest stroke network in the country, which includes about, you can see it's got 9 million patients. So what they did, some of the referring hospitals to them had Brainomics, some of them didn't. So what they did, they compared the door-and-door out time for the referring hospitals with AI and without. And surprisingly, they found the same outcome. The hospitals who were using AI were able to reduce the door-and-door by about 60 minutes. So talking about networks, so this is the direct impact of AI. But there's also an indirect impact of AI because, one of the speakers said that rather than allowing the hospitals to choose whatever they want, and so it's always good to work as a system, work as a network, making sure that you have one AI for the whole system, which is easy to procure, easy to implement, easy to share, easy to trade. So it is the right way to go. So what we did in Thames Valley, all those 5 referring centers and Oxford in the center, which is the comprehensive stroke center, we came together as a network called Titan, that is Thrombectomy Innovation and Transformation Network. And we implemented AI as a system, and we became the first AI-enabled network in the country for stroke. And what this helped us to do is that when we came together, we worked together better. We were able to look at our whole pathway rather than imaging, and also be able to improve the inefficiencies in the pathway. As a result of it, the number of mechanical thrombectomy in Oxford has gone up in the last 4 years from 34 to 200. This is not, again, this is not the direct impact of AI. This is AI enabling people to come together and develop a system that works for our patients and improve the efficacy of the system. And so now, so going back to what's happening with AI in stroke. In the UK, as of January, more than 90% of the hospitals, not all of them are tertiary neuroscience centers, even the acute centers, 90% of the hospitals are using artificial intelligence software for identifying stroke patients. And you might also know, in January, the NICE has published a diagnostic guidance which recommended 2 AI products, which is Brainomics and Rapid AI, for this use, but there's a huge caveat that can be only used in conjunction with the specialist, and also in the professor that we are going to continue to gather evidence. So evidence gathering is absolutely key. So what evidence have we gathered when we implemented across wider networks? So this hard work is done by Health Innovation Network. I think Amrita's speech, she mentioned about the use of Health Innovation Network and how can they help to gather this evidence for us. So they've done a great work as part of the AI award. So these are the comparison of mechanical thrombectomy rates in 26 hospitals that are part of this evaluation compared against the rest of the hospitals in England. And you can clearly see the top graph is at the evaluation centers, which were using Brainomics as part of this evaluation. The mechanical thrombectomy rate was increasing much faster than compared to the other centers. And also, the next slide is very similar to what Susie has shared. So that's sort of an objective evidence looking at numbers. And this is about the survey. So they surveyed about 39 stroke clinicians as part of the evaluation. You see, most of them given a very positive outlook. And again, that you've got a captive audience, you're going to ask the question, they're going to say it's good, isn't it? So there's always a... But they did something very interesting that very similar to what Susie found, is this graph. We asked the same question twice before they've had AI and after they've had AI. So we asked, the question was very simple. Do you think it's going to be useful? And you can see about 25% of the people said, no, we don't think it's going to be useful. It's not going to make a difference. And only 25% thought that there is some benefit in it. This is before they had any experience. And 50% of them were sitting on the fence. And midterm, after they've had a chance to use the AI, can you see the people who were skeptical from 25% to 8%. So clearly there's an experiential effect of using AI and technology in how people perceive its benefit, actually. The more you use, the more familiar you become, then you can see the benefit of this. How am I doing for time? So briefly, the key enablers. So if you're thinking about, there's quite a lot of enablers have been discussed during the morning session. This one thing is that you need to have the right policy, actually. The policy decisions are always key. Well, we were lucky that stroke service model, which had the National Stroke Optimal Imaging Pathway, which we call it NOSEP, which clearly identified where in a stroke imaging pathway AI can be used. So that kind of share the same message to everybody, and it's hard and easier to implement it as part of the system. And obviously the NHS AI award helped us to implement and evaluate the benefit of the AI. And also we've had great system leadership. Of course, the system leadership is absolutely key. And challenges, you've heard all of it. I'm not going to repeat it. it's going to be the same challenges, and we've had great speakers talking about all those challenges. So, in summary, so if you were skeptical walking into this room thinking that can AI be implemented at scale, yes, it can. If you were skeptical about can there be a real benefit to patients and system, we've demonstrated yes, it can be beneficial. So, and the key that I would like to share is that if you're going to do something like that, come together, use it as a network. Working together is either for the pathway improvement or implementation is the best way to move forward. Thank you very much.
Thank you so much. I know we've got lunch now, but I know this was an absolutely fantastic talk and great to hear the experience. Any short questions? Yeah. I think this is really important. You'll just all have to eat quite fast. Sorry.
Sorry, just a very quick question. We have radionics at our site. How much of this advantage is the fact that you've got the images on your phone versus actually AI doing its job? Because our internal audit for stroke, not vessel occlusion, just for stroke, is 50%. So kind of toss the coin. I think the audit is there available on ResearchGate, has been published. So I'd just like to know from your experience, where do you think AI is helping?
Quick answer is that it's about how you integrated AI into the pathway, whether you're using AI for every single image, because if you're using it as an ad hoc, you won't find the benefit. And it's combination actually, because you have easy access to imaging. The second thing is that because because the decision you need to make quickly is two actually. Is it something that I need to just get out of bed and call someone immediately or not? And that information is given to you within about 10 minutes. But if you just use it as an imaging platform, you still have to go through all the images and then make a decision. That's 5 minutes, so that's 5 multiplied by 2 million neurons. So it does have a benefit, but if you don't see that benefit, is look at the pathway and say how it has been incorporated into.
Question here. This will be the same one, so you can skip me.
Yeah, okay.
Hi, I'm I'm a radiologist from Oxford. I liked your survey about the qualitative aspect of the stroke clinicians' perceptions. Have you done something similar with the radiologists? Certainly, anecdotally, the results might be different.
Because I think the two, again, like answer that question. So thank you. And you look at it's all about where the value is. So if the value of this product, as I told you, it's more for the front door clinicians who are not the specialists and who will take 10 minutes to look at the scan and find aspect score and if there's an LVO or not, and they are more likely to find it more useful than an experienced neuroradiologist. They might not find it as useful as the front door clinicians. I'm sure in that survey, one or two radiologists, or I haven't dissected it. Yes, I agree that there's a differential experience.
And just a quick follow-up, in terms of obviously when you're giving to less experienced clinicians, if there's a wrong AI result, it's also likely to influence the wrong way. And how have you seen that in your practice at all? And how is that being monitored?
That's correct. So we have actually, because no system is perfect, no human is perfect, and we've had scans being reported or missed scans. So no one is perfect, including the system. So we have to accept it. As someone else said, that we need to accept that imperfections. And when we analyzed it for LVOs, the positive predictive value for detecting LVO for using brainomics, e-aspects, is about 77%. Negative predictive value is like 90%, which brings us the accuracy of about 90%. So we know that when it says there's no LVO, there's about 10% chance there might be an LVO. So we know that. But we're not too worried about the low positive predictive value because they get referred to comprehensive neuroscience centers, and the specialists can then look at it and then say, no, this is suitable or not suitable. So, I completely agree. It isn't perfect, but it is better than what we had before we implemented it. Thank you.
Hi, thanks for the presentation. It's very interesting. Can I just ask a quick question? How involved were radiologists with your pathway before and after your intervention? Is it all right in thinking they were involved in the minority of cases?
In terms of implementation.
Were your strokes reported by a radiologist?
No, before that, even before, strokes were not reported by the radiologist because reviewed by the stroke clinicians and they made the decision. So that's why because when then you add CT angiograms for all the patients and overnight, and to get the CT angiograms recorded for every single case, it can be quite challenging. So this has been quite helpful for clinicians who are learning to look at CT angiograms and while they're developing their competency. This has been an adjunct to help them. This is almost like, it's like a sat nav. You don't trust it 100%, but it gives you a bit of a guidance that there is the way to go. So that's
Great, thank you.
No, sorry.